Great. Thank you, Julie. Thank you for the organizers for inviting me to speak today on our project of the Interlab proficiency testing scheme for tumor NGS. Sorry, my slides are clicking through. There we go. Interlab proficiency testing scheme for tumor NGS in Ontario clinical labs. Proficiency testing in general terms is a quality assurance tool that enables labs to monitor performance and compare testing results against other labs. And the key purpose is that proficiency testing ensures quality of NGS and other molecular tests, and it is conducted using blinded analysis of samples with known results. NGS for solid tumor molecular profiling is quickly becoming standard of care testing in Canadian clinical labs that are MOH accredited and licensed. And this is due to the high yield of genetic information from NGS, as well as the need for very small amounts of tissue, which allows for tissue preservation, and the increased NGS implementation in clinical labs. In Ontario, licensed and accredited clinical labs are required to participate in proficiency testing, and they're required by the provincial accreditation body, the Institute for Quality Management in Healthcare, or IQMH. And IQMH requires that in order to maintain accreditation, labs complete proficiency testing for 4 samples within a 12-month period for each clinical test that's offered. So there are various options to meet proficiency testing requirements by the IQMH, and these include subscribing to international proficiency testing schemes, informal sample exchange between labs, and also a new initiative of Canadian biomarker quality assurance. And if anyone has any questions about this new initiative, Tracy Stockley is on the line as well, so she can help answer those questions at the end of the talk. And also other clinical labs in other provinces might have additional programs that they use. So there are a few key considerations in the design of a proficiency testing scheme for solid tumor molecular profiling. And one approach is to use an end-to-end proficiency testing scheme, which includes the pre-analytic, analytic, and post-analytic assessment of a tumor sample, whereby FFPE tumor is used as the sample source material, and this is the material that's distributed to the participating labs. The labs then perform their own DNA extraction, NGS sequencing, variant identification, and reporting. And this is an end-to-end based proficiency testing scheme that allows for evaluation of the entire lab system. An alternative approach to this is to use a methods-based proficiency testing scheme, and this focuses on the analytic phase of proficiency testing. So the reference lab conducting the proficiency testing would extract DNA and distribute extracted DNA to the participating labs, who would then perform the analytic components of the proficiency testing. And there are advantages and disadvantages to both approaches. So related to the pre-analytic phase, one of the key considerations in designing a proficiency testing scheme is the sample source material used. So FFPE tumor can be used, which enables the end-to-end evaluation of testing. However, there are some issues related to the use of FFPE tumor material, and that includes that it's difficult to source sufficient tumor material to distribute to each lab. There's also the caveat of potentially suboptimal quality of some FFPE tumor material and tumor heterogeneity. And an alternative approach is to use DNA extracted from FFPE tumor material. And there is the inherent limitation, or so the positive part of this is that you can ensure consistent sample is distributed to each lab, but the inherent limitation that it only allows for evaluation of the analytic phase of testing. And for the post-analytic phase of proficiency testing, there are also considerations related to somatic variant annotation practices. Different approaches and published schemes are available and can be used, including the AMP-ASCO-CAP endorsed guidelines, published by Lee et al. In 2017, or the somatic variant classification guidelines that were developed at UHN and published in 2016, or just the use of lab-developed guidelines for variant reporting. However, although there's no currently consistent approach to how we annotate somatic solid tumor NGS data in Ontario, labs don't necessarily need to do the same thing for quality. A great analogy for this is that we don't all drive the same car, but we all get to where we're going. So in the same way, we don't all use consistent interpretation practices, but we're all capable of identifying the therapeutically actionable variants of interest. So for this study, the objective was to implement a pilot proficiency testing scheme for Ontario labs that were participating in the Ontario-wide Cancer Targeted Nucleic Acid Evaluation Study, or the Octane study. And this was designed as a pre-to-post analytic scheme, and this involved dissemination of FFPE tumor material and return of variants BCF files and information on clinically reported variants. And the key goal of this study was to demonstrate consistency in variant detection across all of the labs in the study. So the Octane study, which I'm sure you're all aware of, is an ongoing prospective clinical trial with the goal to identify specific mutations in patients with advanced solid tumors using NGS. And this is to enable better prediction of tumor behavior and select individualized therapies for patient treatment by genotype drug matching. And the lead PIs on this study are Doctors Phil Bedard and Lillian Su. So at the time that we conducted this study, there were 5 participating centers, including the Princess Margaret Cancer Center at UHN, which was the reference lab for this study, the Juravinski Cancer Center in Hamilton, the London Health Sciences Center, and the Ottawa Hospital and the Kingston Health Sciences Center. For this end-to-end proficiency testing scheme, the reference lab at UHN distributed samples to the 4 participating labs, and these samples had previously been profiled at the reference center and had known variants in known genes, and the tumor site and histology was also indicated. For each case, the labs received 2 FFPE slides and 1 H&E slide. The labs then performed routine clinical testing, including tumor assessment, sample processing, sequencing, and variant identification. And this was followed by variant interpretation and reporting. So this included reporting of genes that were reported for each tumor site, reporting of clinically reportable variants using HGVS nomenclature, and also providing VCFs. And this information was sent back to UHN to perform a comparative assessment. So we compared the clinically reported variants by each lab, as well as the quality assessment of variants that were technically identified. For the 10 FFPE tumor specimens, these were obtained from surgical resections of Octane patients. And some of the sample selection criteria included that the patient provided additional consent for the tissue to be used for this purpose, that there was a variety of genes and variants known from prior clinical testing at the reference lab, that the sample had a minimum of 20% tumor cellularity, and that there was sufficient FFPE tumor material for distribution to all 4 participating labs. And the material was provided on unstained, uncircled, air-dried, uncoated slides, and sections were numbered as they were cut in order to track distribution of which samples were given to each, or which slides were given to each lab. And tumor site and histology was provided, as well as providing an H&E. For the NGS sequencing assay used, the reference lab at UHN in the Princess Margaret Cancer Center in the AMSL lab used the Hi5 panel version 1. This is a custom hybridization capture NGS panel for DNA sequencing only, and it includes 555 cancer-related genes and is sequenced on the Illumina NextSeq platform. The 4 participating labs at the time were using the ION AmpliSeq Cancer Hotspot Panel version 2, which is a commercial Amplicon-based hotspot panel for DNA sequencing, and it includes regions of 50 genes and is sequenced on the ION Torrent PGM platform. In terms of what was requested from the participating labs, we requested that the labs provide a list of all genes reported for each tumor site, and that they provide a list of any variants that they would consider to be normally clinically reported through routine practice for Octane, including variant interpretations. We also requested that labs provide the VCF files to do an informatic comparative assessment. 6 tumor types were included in the study, including melanoma, colorectal adenocarcinoma, low-grade ovarian serous carcinoma, liver adenocarcinoma, and parathyroid carcinoma, and lung adenocarcinoma. And this table provides the list of reportable genes for each tumor site that was provided by each lab. So 2 labs decided to report on all genes that were included on their panel. 1 lab reported on a subset of genes for each tumor site, and 1 lab reported only variants in genes that they would normally report in clinical practice at that center. So as you can see, there was some variation in what labs chose to report on in terms of the gene list. We also evaluated the technical performance and identification of variants by each lab using the raw sequencing data that we obtained from the VCF files. So we identified 98 of 98 exonic variants that were found in the VCF files from all 5 labs across the 10 cases were concordantly reported or detected. And although we observed no difference in the final exonic variants that were identified, we did note that 28 of the 98 variants identified by 1 or more labs were identified below the threshold defined for proficiency testing evaluations. So below the lower variant allele frequency or depth of coverage cutoffs that we used for our analysis. So one important thing to note is that these low variant allele frequency or low coverage variants, of those, none of them were considered to be clinically reportable by more than 1 site. So it's not unexpected that we would see some variability in the coverage that for each sample. So we also evaluated concordance in the reporting of variants that were considered to be clinically reportable by each of the labs. And we found that only 3 variants across the 10 cases were concordantly reported by the 5 participating labs. This result also is expected, and it's really, I think, due to the lack of national provincial standards for variant classification and interpretation that I mentioned previously. So 4 labs chose to classify variants using a published variant classification scheme. 3 labs used the AMP-ASCO-CAP endorsed guideline, and 1 lab used the Sukai et al. System. And so this really is expected that there would be some variability in classification. And to provide an example of this, I'm showing a melanoma case in the bottom panel here. Of the 5 variants that were identified in this case, if you look at the middle one, the NRAS glutamine 61 lysine variant that was reported by all labs, you'll see that this variant was reported as a tier 1 or class 1 variant by 2 labs. It was reported as a tier 1/2 variant by 1 lab. It was reported as a tier 2 or class 2 variant by another lab, and the 5th lab reported the variant, but they did not classify it. So you can see some variability there. Also, 1 lab, which is site 2 in this case, reported and classified all variants that happened in the case or that occurred in the case, including tier 4 variants, which would typically be considered to be benign variants. So there were some important sample selection considerations that related to the differences in these results. Firstly, it was difficult to source sufficient FFP tumor tissue that met the other parameters of sample quality and sufficient material. So of the 10 samples, 4 were ovarian tumors, and ovarian tumors tend to be generally large surgical specimens that have sufficient cellularity and that lack necrosis. And only 2 of the samples were lung tumors, and 1 was a colorectal tumor. And these 2 tumor types represent the most common tumor types that undergo NGS testing as standard of care in Ontario. So due to the small tumor specimens that are generally obtained from lung and colorectal samples, it was difficult to source sufficient material for the study for those tumor types. So this led to some bias in sample selection that may have impacted sample interpretation and reporting in the proficiency testing scheme, because all participating labs routinely test lung and colorectal cancer, but only 3 of the 5 participating labs typically report on ovarian cancer. Furthermore, this variability might attribute to furthermore, there's some variability also that was identified in the variants that were detected at the quality filters that we use, so 28 of the 98 variants that were identified. And there are a number of potential sources for the variability in this detection. So it could result from tumor heterogeneity. It also could result from differences in pre-analytic sample processing or NGS quality, or also differences in the sequencing platforms that were used at the different centers. So it's difficult to further delineate the source of this difference in this style of proficiency testing scheme. So we also observed differences in variant interpretation and reporting, with only 3 variants that were clinically reported by all participating labs. And this is due to a couple of factors. There's variability due to differences in variant classification and interpretation of what's considered to be clinically reportable, and also site-specific interpretation of the proficiency testing scheme instructions that we provided. We also found that there was no consensus on the classification scheme that was applied. So 3 labs used the AMP-ASCO CAP endorsed guidelines, and of those 3 labs, 1 reported on all tier 1 to 4 variants, and the other 2 labs reported on tier 1 and 2. And another lab used the SUCHI et al. Guidelines, and the 5th lab did not use a guideline for reporting. So in conclusion, this pilot solid tumor proficiency testing study demonstrates the feasibility of an end-to-end tumor NGS approach for proficiency testing in the Canadian clinical lab context. And we did identify some challenges, including challenges related to sample source material selection, evaluation specifically of the NGS quality rather than of the pre-analytic elements as well, and site-specific practices for variant interpretation and reporting. So what this study established is that there was technical quality of the labs that were included in the Octane study at that time, 100% concordance in the technical identification of variants across the labs and sequencing platforms. But there was variability that was noted in the interpretation and reporting, which highlights a need for defining clinically relevant genes and variants in the Octane study, as well as possible identification of a common approach to variant reporting. And just for some more reading or information, I just want to refer you to our recent publication in Current Oncology. This study was published in December 2019. And I'd like to acknowledge everyone at the University Health Network that was involved in this study, including those in the Octane study and the individuals at the participating centers in Kingston, Ottawa, Hamilton, and London. And myself and I think Tracy Stockley is also on the line for any questions. Thank you.